Good evening, my dear professors and colleague. I'm Fadi Magdi on behalf of the Oman Society of Nephrology and Transplant. Welcome to our monthly CPD virtual meeting. Today we have interesting case presentations by Dr. Fatima Al-Kindi. I would like to invite Professor YOUSEF boobes. He's a consultant nephrologist at Seha Kidney Care UAE. Please, Professor YOUSEF, the floor is yours to introduce Dr. Fatma and moderate the talk today.
Assalamu alaikum. Good evening. It's my pleasure to be with you this night. In fact, Dr. Fatima Al-Kindi is one of my best colleagues that I've met in the last maybe 2 decades. She is very bright, very active, very keen for her patient, and she contributing very actively in research and publication. Dr. Fatima worked very close to inside our team in plasma exchange, and she gained a huge experience in that regard. Also, she is very expert in extracorporeal method for blood purification, including CRRT and hemodialysis. So we are very excited to hear from her the cases that she will present today, inshallah. So Dr. Fatima, please, the floor is yours.
Assalamu alaikum wa rahmatullah. Thank you, Professor YOUSEF and our esteemed colleagues, and we also would like to thank the Oman Society of Nephrology and Transplantation for their kind invitation, Professor Isa Salmi and Dr. Saja, and we are honored to have my dear professors, Professor YOUSEF Boobes, moderating this session. I'm honored for that, and Professor Hisham Said, who was my mentor and the program director for the online renal RRT fellowship. Today we would like to share with you some interesting cases that we have gone through during my stay with the nephrology team. And the aim of this presentation, it will be interactive. So hopefully I would like to hear from everyone attending this session. So, case number 1, edema and hemodialysis patient. We had this gentleman who was 54 years old, and this Bangladeshi gentleman who was known to have hypertension, long-standing, along with dyslipidemia, and uncontrolled diabetes type 2, and he was maintained on oral medications, namely metformin 1 gram twice daily. And he's known to have chronic kidney disease, but he was not really following up for that, and he is also having some diabetic retinopathy. 2 years ago, he presented to the private hospital because of diabetic foot cellulitis, and for which he required incision and drainage. At that time, during his hospital stay, he was kept on vancomycin and piperacillin tazobactam for 1 week, and over time he developed a progressive AKI on CKD, and he was initiated on hemodialysis. After the 3rd session of hemodialysis, he started to produce some urine, so the team at that time decided that they will hold dialysis, and they were discharged from home with a follow-up in the clinic. The patient did not follow up with the private hospital, but instead he came to our hospital with a few days history of progressive shortness of breath. At this time also he had a reduced urine output, and there was marked swelling involving his upper limb and lower limbs. He denied any fever, and he denied any history of TB exposure before. So when he came in to our hospital, his initial labs showed mild hyponatremia of 130, creatinine of 813, with the urea of 25. He also had a mild hypercalcemia, and at that time he has a leukocytosis with anemia of 8.7 with reactive thrombocytosis. And you can see his X-ray showing some left-sided mild pleural effusion with increased bronchovascular marking, suggestive of some early pulmonary edema. And he had a normal-sized kidney with echogenicity. And markedly at that time, I was fortunate to take his photos of the upper limbs. You can see his edema is really massive in his upper limbs and lower limbs. Because of that condition, patient was having respiratory failure, secondary to volume overload, and advanced end-stage renal disease. Because of underlying diabetic nephropathy, the patient was initiated in hemodialysis. This is an easy start to start with. Volume overload, dialysis patient, but the story did not end up at this stage. So we have done for this patient 5 hemodialysis sessions during his hospital stay with almost 10 liters UF in total. At that time, almost 1 week, we are in the first week of admission, you can notice his lower limb edema almost resolved, but the upper limb edema was persisting. So at that stage, we thought we have to investigate further what's going on with this patient. Any suggestion at this stage?
Any central
Excuse
line?
me,
Any central line? No, he had a femoral line. No previous IJ line.
Astonishing, starting by femoral catheter. Do you have an explanation for that?
A patient was not able to lie down. Later on, Bermacath was inserted. Internal jugular after his hypoxia
What
improved.
is his albumin level, total protein and albumin?
That's a good question. Total albumin and this patient was 28, and total protein was around 60.
Echo finding, he did echo heart.
We are coming to that. Yes. And we did echo for the patient. Echo at that stage showing some LVH picture with ejection fraction of 65%, diastolic heart failure stage 1. No valvular disease.
I think in my clinical experiences, such edema in the upper limbs involving, beside venous stasis, patient is lying recompensating all the time. So edema in the lower limbs may be masked. However, upper limbs may still swollen. I cannot just forget for that for the lower limb. What about the sacral edema, which is very important point here?
Thank you, Professor. When he came in, he has sacral edema, but after this good sessions of hemodialysis, sacral edema improved, and he was able to mobilize, but he cannot use his hand because of the severe edema that he has in bilateral upper limbs.
And patient definitely has autonomic neuropathy.
To some degree, yes. So at this stage, we thought, okay, thank you for your contribution. We will continue and then also get back. So at this stage, we thought, are we missing something else? Do we need to rule out cellulitis that's masked because of the clinical condition? We did also X-ray to rule out any inflammatory conditions that we also not aware of. So the X-ray, I hope you can see it. There was no erosions, and the ultrasounds showed some edema and the interstitial edema with cobblestone appearance and mild tenosynovitis, nothing major there. At this stage, patient was started empirically on antibiotics with piperacillin tazobactam for possible cellulitis in the upper limbs. And at the same time, we continue UF with hemodialysis This time reaching with the 7th session of hemodialysis, more than 15 liters of total UF. We sent the serology for an autoimmune workup. They were negative. We sent the uric acid, that was also negative. And he do not have a long-standing long-standing hemodialysis to think of amyloidosis or something else. But we sent the ESR. ESR was also elevated. The rest of autoimmune workup was negative. At this time, we also think what's going on with this patient. And you can see at this time, in the picture I was showing you, the pitting edema and bilateral hands, slightly better than the previous one, but still not completely resolved, and patient still complaining of pain, and he cannot use his hands. At this stage, we asked the primary team, the internal medicine, to consult rheumatology. The rheumatology, when seeing all the labs normal, they said, this is less likely to be a rheumatological condition. Please manage the patient. This is volume overload secondary to dialysis. Central venous stenosis was ruled out, and superior vena cava was patent by the CT with contrast and the upper chest.
Excuse me, what was
Now,
the indication for the rheumatology consultation? What was it about precisely?
why this patient he cannot use his hands, with evidence of tenosynovitis and edema, and a negative serology of this patient. So we really did not know what's going on. We wanted some answer. We did not think this is related to dialysis or volume overload, because clinically we try to dry this patient out with more than UF, more than 15 liters of UF over 10 days, but we could not find an answer. And now I will keep it open for discussion if you would like to help us to reach the diagnosis of this patient.
Did you give
So what do you
albumin?
think is going on?
Did you give albumin with dialysis?
No, we did not give albumin. And when we repeated albumin later on, it was improved to 30 after 10 days of hospital stay.
Each 1 gram of albumin can retain about 20 milli of water. So did you find any trouble using ultrafiltration and hemodynamic stability during ultrafiltration?
It was the opposite. He was on hypertensive medications, and we reduced and even stopped majority of them because he's tried to drop his blood pressure during dialysis and more UF.
To my opinion, this patient should take albumin with dialysis.
I appreciated the Professor Hisham. Any other answers for any other?
Sorry,
Professor Yusuf, yes,
if you allow me, Professor Hisham, I might disagree about albumin, that he should take that. Patient, it's not a problem of generalized edema. It looks like localized edema. His albumin is acceptable in the range of 30, and we don't have any instability. So in my practice, in such cases, I will try to avoid albumin because it will, and I don't know if it will help. But anyhow, it's well taken. Sorry, if anybody keep... can we close? I don't know who is
the admin. Who is the admin? Just to mute.
Admin, just mute, please, others.
Fadi, I think you are the admin.
ايوه دكتور هشام هعمل ميوت
Okay, thank you. Anyhow, it's a different opinion, but it's well taken, Professor Hisham. Go ahead, Dr.
Fatima. So thanks, Professor. So any other suggestion what's going on for this patient? What is your diagnosis? And okay, if there is no diagnosis, how you will treat this patient?
Hello, Dr. Fadi. Hello.
Yes.
Hello. I want to ask if we have a rule to exclude leptospirosis here.
That's very nice, unusual diagnosis. Patient did not exhibit further other manifestation of leptospirosis, and that's we did not exclude it to start with. This because leptospirosis has its own manifestation. I mean, in terms of renal and extrarenal manifestations and exposure to rats, but this was not in his case.
Okay.
Hello. Fatima, about the thyroid function test, if he has severe hypertension, hematuria, what about systemic sclerosis findings? As he received
Right.
the tazocine plus vancomycin, something like this.
Sorry, the voice is not clear. Did you got the question, Doctora?
The listing of thyroid function test, and I'm asking about any signs suggesting systemic sclerosis.
Yes,
Hello?
Doctora Fatima.
Dr. Fatima? Hello?
Okay. Now you can hear me?
Yes.
Yes.
Okay. So thyroid function test was normal, and there was no other manifestations that could suggest scleroderma. And we sent the scleroderma screening antibodies. It was negative.
And it's pitting edema. I can see that it's a pitting edema related to volume rather than venous hypertension or mixed edema. It is true pitting edema.
Dr. Fatima, Assalamu alaikum.
Walaikum salam. Appreciate it, Prof. Yes.
Doctor, I have a question. Did we يعني he had hypercalcemia on presentation. Do we have
Yes.
explanation for this? And did we like screen him for multiple myeloma? We know he has diabetes. He was labeled diabetic kidney disease.
Wallahi, excellent thought, Doctor, and we will answer your question during the discussion of this case, inshallah.
Another
Okay.
question, Doctor. He had peripheral neuropathy, صح? في lower limbs, who most probably attributed to his diabetes.
Yes.
Do we know if he has the same symptoms on his upper limbs? يعني bilaterally, do we know if he has any peripheral neuropathy?
Not much. I mean, sensation in the upper limbs is really intact, but he
تمام،
has
شكراً.
this limitation.
شكراً.
But for the multiple myeloma, we send the test and we will show you the result later, inshallah. So to move in this case, thank you for your active participation. The same for me. I have experience in nephrology, alhamdulillah. I have experience in ID. I also have experience in medicine. So I thought, what's going on? I started reading, opening the Harrison book. You know, sometimes you would like to help your patients. You go back, you Google it, you could not find it. You open your old books, trying to figure out what's going on. Also, I could not find an answer. Until one day, I was the weekend on call. And before, usually, before the on-call, before I review my cases, I will open some MCQs. I'm following up some of the professors on Twitter or the X, now they name it. So I used to follow them up, answering some of their challenging questions and seeing if I will learn something new before I open and review my patients. And exactly on that week, the professor Aaron, he is well-known hematologist, posted something there. He mentioned, I just learned about this disease that I saw in the clinic that I never heard or saw before. And he mentioned he had hematology patients who had bilateral upper limb edema, symmetrical in the dorsum of the hands and feet. And that disease called the following: remitting, seronegative, symmetrical synovitis with pitting edema. And subhanallah, at the same time, Dr. Nihal, who is also a well-known nephrologist in UAE and working in Al Ain with our team, she also saw the same post and she sent it to me and she said, Dr. Fatma, most likely our patient having this disease. So we read about this disease and how it's manifested, and we try to look if our patients have this disease or not. So what is remitting seronegative symmetrical synovitis with bedding edema? It's from the name. It was first described by Dr. McCarthy in 1985, and he described 8 cases, and they named them. They have this box glove hands. As the name indicated, it has usually acute onset, and it's bilateral, symmetrical on both upper limbs and lower limbs, with evidence of synovitis and edema involving the hands and feet. Usually, rheumatoid factor will be negative, and it's usually affecting elderly, age more than 50 years, with more predominant male compared to female by 2-to-1 ratio. The global incidence is unknown, but you can categorize it according to the three main etiologies. It could be idiopathic in some of the cases. It could be drug-induced, like patients who was just initiated on insulin or DBV4, or use some antibiotics like rifampicin, or could be infection-related, like Staph aureus, Pseudomonas, Klebsiella, and they also link that to diabetic infection, like diabetic cellulitis or diabetic foot disease. Also, they mentioned they should not forget the other link with other rheumatological disease, like polymyalgia rheumatica and late onset seronegative rheumatoid arthritis or even Sjogren. In some of the cases, you have to consider age-related screening for malignancies, as paraneoplastic syndrome can present with this remitting seronegative symmetrical synovitis with bedding edema feature. So how common to have this disease in dialysis patient? The first case was described in 2012 by the Japanese team, in which a 75 years old man who was maintained on hemodialysis for more than 23 years, and he developed over 3 months progressive hand swelling and feet swelling, and they diagnosed him with this remitting seronegative symmetrical synovitis with bedding edema, and he completely responded to prednisolone tapering over 6 months. The second case was published in 2016, again by the Japanese team, for a patient who was maintained on dialysis for 9 years, and then he also non-diabetes uncontrolled, and he was having this disease and responding to steroids. A third case was there, published again from the Japanese team in 2020. Patients who was 5 years on hemodialysis, a 71 years old man with 5 weeks history of this. This time he had shoulder pain and other joint pains with evidence of synovitis as in the picture, and he responded also to steroid. And they described the 3 cases that was published in literature, and the common thing, they are all male, they all above 50, and they with the presence of diabetes only in 1 patient. And you can see they are longer standing on diabetes. They was from 5 to 23 years, and they responded well to steroid. It's a self-limiting disease. How about our case? What happens to our patient? When we reviewed this case, we thought we are dealing with the most likely diagnosis. Our patient having initially, before presenting to us, he was having a diabetic foot infection, and he was receiving insulin for the first time. So these both are triggers. And then despite giving him all the therapies here, he was not responding. So then we decided we will start him on steroid. And we started lower than what is recommended in literature. I recommended 20 milligram, 20 to 30 milligram tapering over 3 to 6 months. In our case, we started him with 15 milligram for 2 days, but we had uncontrolled diabetes, hyperglycemia. So we had to reduce the dose to 10 milligram for 1 week. And alhamdulillah, thankfully, his edema responded well. This is after the third day of steroid. You can see, mashallah, dramatic improvement. And as in literature, we have to screen for other concomitant paraneoplastic our malignancy. Because of the evidence of hypercalcemia and anemia, we sent the Kappa lambda. It was elevated with a normal ratio of 1.6, and we have done protein electrophoresis that was showing polyclonal gammopathy and seen by hematology, less likely to be multiple myeloma. And he was only treated for 1 week, and alhamdulillah, he maintained remission over 3 years. And thankfully, we also presented this case in China in the International Chinese Rheumatology Conference, and it was one of the best overseas abstracts awarded for travel grants. And alhamdulillah, I got the chance to be presenting there, and with our prestigious team from Tawam Hospital. This was the first case we had, rare, but it is there. Our case added as a fourth case in literature for this remitting seronegative. So to recap, the remitting seronegative symmetrical synovitis with pitting edema. This it could be acute, presenting over days to weeks with symmetrical synovitis and tenosynovitis affecting the hands and feet, more elderly, as we mentioned, and more with male predominant. Extra-articular features is usually less common, and you have to diagnostic based on the criteria. It's pitting edema, it's active synovitis, age more than 50, with negative rheumatoid factor, and negative CCB, and you can see ESR or CRP might be elevated in some patient. Relatively, if you do imaging, not much, maybe tenosynovitis or even edema there. And please remember to the association with malignancy, or it could be as related to recent infection or drugs like insulin or antibiotics. Treatment, low-dose steroids, and usually patients improved. It could be a 3 to 6 weeks therapy. It could be prolonged. It's only based on case series and case reports. There is no dedicated guidelines for the treatment duration of steroid. Our patient responded with 1 week, alhamdulillah, therapy. It can happen again for the patients, but usually has excellent prognosis and outcomes. Thanks, and this was the first case, and we will move to the second case. Do you have any question for the first case?
This is disease of elderly. I notice age onset is high, more than 60, 70. That
Yes.
you have presented reported cases.
This is the current, yeah, it's more than age, more than 15. This is also part of the diagnostic criteria.
It can affect the feet also, the same like the hands?
Bilateral, yes. This is what happens to our patient. Initial presentation, bilateral upper and feet and hands. But his feet improved and the hands persist.
I liked your comment, Fatima, for the return maybe recurrent, and this is called typically palindromic type of synovitis. And the term palindromic is coming from the Greek name of return pal. So we can put it under the diagnosis of palindromic rheumatism or palindromic synovitis, because you said that it may recur. Yes, it may recur, and many of these such a synovitis may recur without obvious precipitating factor. But just to know that the term palindromic, you can search on that palindromic, and coming from the Greek name of return pal.
Appreciated, Professor. Thank you so much. So, Professor YOUSEF, would you like us to go to the next case?
Yeah, go ahead, please.
Inshallah. So the next case is again one of the challenging cases, but now we'll move to a kidney transplant patient. So this is our patient. He's from Bangladesh. He was 50 years old. He is known to have end-stage renal disease since 2009. There was no biopsy, and they don't know what's the underlying cause. He required dialysis for 1 year, and then he had kidney transplant from living-related donor, his cousin, in SKMC Hospital in United Arab Emirates in December 2012. And he had a relatively stable allograft function. Apart from other condition, he has hypertension. He was maintained on tacrolimus and mycophenolate mofetil 750 BID. He came to the Tawam Hospital because of 2 weeks history of fever and weight loss. It was associated with abdominal pain. He also reported severe bloody diarrhea more than 20 times per day. He had poor oral intake. There was no oral ulcers and no skin rash, no joint pain, and his urine output was maintained.
Is it a steroid-free protocol?
For this patient, yes. In his initial investigation showed that he has mild hyponatremia, creatinine in his baseline around 99. He has significant leukocytosis with around 24,000 with a presence of anemia and reactive thrombocytosis. And you can see his X-ray. There was multiple dilatation, but there was no air fluid levels. And the ultrasound abdomen showed this finding. What do you think this finding is? Okay, so the answer to this, this ultrasound finding showing evidence of colitis. This is the colon that is inflamed with the presence of edema surrounding it. This was my first time to see a colitis picture from the ultrasound finding. So this patient was diagnosed with severe colitis based on ultrasound finding. So part of the workup, we sent for him stool cultures, blood cultures, and we arranged for urgent colonoscopy. We sent the CMV workup also. And the colonoscopy was done for the patient within 48 hours. After good preparation, it showed that he had moderate to severe ulcerative pancolitis throughout the colon with some erosions in the ileum area in which they took multiple biopsies. Okay, at this stage, what is your differential diagnosis?
CMV colitis would be.
Dr.
CMV
Fatima,
colitis?
the
Yes.
presentation was so acute, right?
Yeah, it is almost 2 weeks
Acute
only.
presentation.
It is 2 weeks only, Doctora. 2 weeks
This is
history of
against
fever, abdominal
CMV.
pain with
CMV is
diarrhea.
more prodromic and chronic. Yeah.
So you think it could be CMV or it could not be CMV? So other suggestion? Drug-induced, like
MMF.
MMF
Yes.
colitis, mashallah. He is after 10 years being on MMF, he will still have now the MMF colitis. It is one of the differential diagnoses and one of the possibilities. Other?
It could be malignancy or something like this. Malignancy.
Could be malignancy.
Malignancy, opportunistic infections.
Opportunistic infection.
This is
okay.
Yeah.
That's good. Thank you so much for your contributions. So yes, the differential diagnosis was wide at the beginning of this patient because of severe, moderate to severe ulcerative pancolitis, and this patient who did not have any previous history of any other medical condition apart from kidney transplant and hypertension. The differential diagnosis initially that could it be infectious colitis because he is on immunosuppressive medications, but what infection can give you all this severe pancolitis? CMV usually patchy, can give you ulcerations, but with this severity, the discussion even was with the GI, they did not see something similar to this. Then could it be colitis secondary to a medication like MMF, which is again a rare entity based on case reports. We know MMF can give you GI side effects like nausea, vomiting, abdominal pain, some colitis, some ulcerations, but with this severity, Allahu Alam. So this was one, the differential diagnosis. The third one was, are we dealing with the inflammatory bowel disease that is now de novo developed after kidney transplantation? It was there, one of the differential diagnoses, and we tried to search out. It's rarely reported, but again, it might be one of the findings that we are dealing with. So at this stage, we have to manage these patients. We have did MDT, nephrology, internal medicine, and GI team. And these patients, they decided because of the possibility of MMF colitis that they change MMF 750 BD to a reduced dose of myfortic 180 milligram BD. And they sent the tacrolimus trough level. At that time, it was low. Despite the fact that we know that patients, when they have diarrhea, usually they will have high tacrolimus trough level, but this patient was in the lower side. The tacrolimus dose was increased to 2 milligram twice daily. And we were waiting for the results of the cultures. And we sent the gastrointestinal PCR that we had, and it turns out to be a negative for majority of the things, including Vibrio and other bloody, other infections that can give you, bloody diarrhea. And at this stage, after discussion with the GI team, because the patient was not improving, we thought now we should hit hard with methylprednisolone, and because of the possibility of MMF-related colitis, later on MMF, myfortic was stopped, and azathioprine was added. So then we also were waiting for the biopsy results, and the biopsy turned out to be from the colon showing active colitis with cryptitis and hyperplastic epithelium, but there was no granuloma. He's from Bangladesh, and we thought, could it be TB manifesting with this severity or something else? There was no granuloma. AFP screen was negative, fungal screen was negative, no microorganism was seen, not even malignancy. So malignancy was ruled out at this stage. The terminal ileum showed evidence of some villus structure preserved, but increased eosinophil and plasma cells there. And when we discussed with the pathologist at that stage, she told us something. Now, presence of, you can see presence of heavy eosinophilic infiltrate with plasma cells, suggestive of, could it be a drug-related, colitis? At the same time, she mentioned there was cryptitis and crypt abscesses, and it could also be seen in patients with ulcerative colitis. So we were in between the two things, but they could not see any signs of CMV colitis at this stage. And the suggestion here, could it be drug-induced more than de novo ulcerative colitis? Nephrology suggesting something, GI was thinking of something else. And now at this stage, the MMF colitis possibility was in the top, followed by de novo post-transplant ulcerative colitis, and it's likely to be infectious colitis, as majority of the investigation was negative for any infectious etiology. Myfortic was stopped. The patient was started on azathioprine, 75 milligram, and we repeated at that time again the tacrolimus level, and it was still low, around 2. This is after increasing it. So at this time, we increased tacrolimus to 3 milligram twice daily, and we changed the methylprednisolone from IV form to oral form, 40 milligram. And the patient was improving. We sent other labs, including all the autoimmune workup, and surprisingly, we found his ESR was high. Along with that, C and K was positive. Now, we did not have any previous C-ANCA results for the patient before, even before transplantation. But this time we have done it and it was positive. So what do you think at this stage is your diagnosis?
How's it wrong? Positive, the C-ANCA.
C-ANCA was 99. It's higher. يعني low, normal less than 4.
You know that sometimes the C-ANCA associated with malignancy, with also infection, it still could be just like bystander rather than active true vasculitis.
Okay, thank you, Dr. Saja.
Doctor, I have a question.
Yes, تفضل دكتور.
Do we know if his symptoms actually improved after holding the Myfortic by this stage?
Now he is still in hospital, and the patient was still symptomatic, having bloody diarrhea. It's improving compared. When he was admitted more than 20 times, now improved to around 6 to 8 times per day. That's why we hold it completely, and we started azathioprine along with increasing tacrolimus. And Dr. Saja, thank you for your input. Agree. C-ANCA could be reactive, but we repeated that again. It was increasing, and when we read about it, it is linked to severe ulceration in the colon. Some patients who have severe ulceration in the colon, they might have C-ANCA positivity, and this will indicate severe mucosal injury. And the patient might respond to some of the biological therapy rather than oral medications. Okay, so at this stage, let's move. Okay, it's getting stuck, but we will see. So can I ask you, how common have you seen MMF colitis with this severity?
Common,
Doctor,
quite.
It's
With
very
this severity of colon?
Yes, I
Colonoscopy.
saw a patient who passed away because of this issue. And actually, it was always a question that I would always ask myself and ask my colleague, which is, why are we ignoring azathioprine that much, which is a GI-friendly medication? And in my humble experience, it's not a big experience, of course, but I saw a lot of patients who are being maintained on azathioprine and they are doing very good.
Okay, thank you, Doctor, for your input. We will discuss this further, inshallah, later on. But
Doctor,
for us, تفضل دكتور.
I know so far we've been blaming the MMF, but anyone suggested that this could actually be related to the tacrolimus? I remember having one patient with mouth ulceration, and we blamed the tacrolimus. And when we discussed I discussed with the gastro personally, قالوا they see sometimes it's in their cases, the liver cases, the tacrolimus can actually cause very severe colitis. It can actually cause the de novo هذا IBD. It's usually more severe than what we see usually for the usual IBDs.
Okay, appreciate it, Dr. Mohammed. We will discuss this further. Again, thank you for your input. Yes, it has been described in patients with liver transplantation who was maintained on high doses of, who were maintained on tacrolimus. Some of the patients, along with the tacrolimus-related kidney injury, they might develop post-transplant inflammatory bowel disease, and they link it to tacrolimus more than MMF, as you mentioned, but this was only in liver transplant. As I mentioned to you, de novo post-transplant IBD is post-kidney transplantation is really very rare. When I tried to read about it, it was not much reported in literature. So we will continue our discussion.
Doctora, excuse me. I think this is very good thought about tacrolimus. However, this patient has a very low trough level, as you saw. And I saw a couple of cases, lesion related to tacrolimus. It was mainly ischemic. Even in one case, required partial colectomy due to severe ischemia, and it was mainly due to tacrolimus. So what we can stress here, it is very important to rule out the relationship between these lesions and medication that patient is receiving. Thank you.
Appreciated, Professor. So we'll continue, inshallah, the discussion of this patient. Okay, Bismillah.
What is his BB medication? He's not on hydralazine.
Blood pressure. I appreciate Dr. Saja for hydralazine-induced vasculitis. No, he was not on hydralazine. He was only in amlodipine, 10 milligram. And so now, because of this, what could be the clinical and laboratory findings that can give you a hint what's going on, how you prioritize one differential diagnosis over the other? CMV colitis, patient would have fever, abdominal pain. You will find pancytopenia, and with positive viremia sometimes, or tissue positive CMV, invasive CMV in colonoscopy. You might find some patchy ulcerations or multiple erosions, and the CMV will be positive in immunohistochemistry, and you know the therapeutic therapy protocol for that. For MMF colitis, patients might have some diarrhea, again leukopenia might be there. Endoscopy, patients might have some erosions, ulcers, and some 50% of the patient, they would have normal colonoscopy finding. Again, here in the MMF colitis, you will send focal cryptitis. You will find eosinophil infiltrates. That was seen in our case, and some ulcerations. And de novo IBD, you would find bloody diarrhea. Patients will present like anyone with inflammatory bowel disease, with high CRP, and depending if it was pancolitis and ulcerative colitis or Crohn's-like picture, with severe inflammation suggestive of Crohn's or ulcerative colitis as there, and there is treatment protocol for this also. So what happens to our patients after we change him to azathioprine and we increase the tacrolimus dose, and we also taper the IV methylprednisolone to oral prednisolone? We did repeat sigmoidoscopy and focal colonoscopy, and again you can see he is in severe colitis. At this stage, we decided with the GI team to give this patient biological therapy, and they classify him as Mayo class 2, and this is how the Mayo classification based on the based on colonoscopy. Our patient was in moderate to severe range, and he also had severe diarrhea more than 6 times. It's bloody, and he has anemia with high ESR and high CRP. So he's a moderate severe picture, and now majority of the time you can escalate depending on the case. You start therapeutic agents from 5-ASA to steroid. If not responding, you will add immune modulator like azathioprine. If not, biological surgery before you reach the end stage with surgery. And now they relatively like, because of the severity of the patient, you should start with biological therapy and come down, de-escalate later on when the patient is improving. So in our patient, the patient was started on the biological therapy called vedolizumab, which is an antibody against the alpha-4 beta-7 and mid-cap, which is linking the white PCs in the mucosa and preventing it from infiltrating and affecting the mucosa of the colon. This is a new medication with a limited action on the GI, limited some of the side effects compared to the other medication like infliximab. And patient was again on the cocktail azathioprine at this stage increased to 100 milligram, and tacrolimus was also increased to 3.5 milligram BD because trough level was also around the 3, it was low. So our patient, after we sent him home with this first dose, so he needs to come after 2 weeks to take the second dose. But the patient did not show up to the clinic because of the insurance issue. And exactly a month later, by the end of that month, he came because of the abdominal pain, polyuria, polydipsia. And this patient at this stage, he was diagnosed to have a new onset diabetes with HbA1c of 13%, and that was prednisolone steroid induced. So they treated him. He required admission. He was initially in DKA. They gave him insulin therapy, and his clinical condition improved. And later on, we arranged for one admission, and almost after 1 month from the first dose, and he received the second dose of vedolizumab therapy, and he was continued on other immune suppressive medications. At this stage, patient clinically improved. His bloody diarrhea almost resolved, and patient was doing fine. And we asked him to come up for the third dose after almost after a month from this dose. But the patient did not show up, and we have to call him back for that almost 2 months later, or 3 months later. So this patient, when we call him to come to the ER on June to take the third dose of vedolizumab, he was clinically stable. He was not complaining of any abdominal pain, bloody diarrhea almost resolved, and he was maintained on tacrolimus 3.5 milligram BD. He's in azathioprine. He's completely off steroid, and his HbA1c repeated at that stage was 6.2. He was off insulin, and he was in reduced dose of oral medication. He was maintained on metformin 500 milligram twice daily. So when we talk to the IGI team at this stage, because of the patient, he's not coming regularly to the clinic, and he only received 2 doses of vedolizumab. And now they want to give the third dose. But before giving the third dose, the GI team decided to do for him colonoscopy to see the stage of his disease, if he responded or not. And surprisingly, mashallah, alhamdulillah, his colonoscopy was completely normal. At this stage, the GI team looked at the nephrology team and said, now we think this patient, he did not have de novo post-transplant ulcerative
Drug
colitis.
induced. Yes, drug
We
induced.
thought this could be drug induced. So they were happy that they win the battle between us. I mean, we were discussing, reading back and forth, GI and nephro. So they thought this could be most likely drug induced, and now he responded very nicely, and no need to give him more therapy. We will observe him closely in the clinic. Again, he has his insurance is not covering the GI clinic in our hospital, but it was covering the nephrology follow-up. So he was maintaining follow-up in nephrology and not seeing the GI team until he started to develop one-time bloody diarrhea. It was in November, and they did for him scope. It was again normal. They found external hemorrhoid. It was managed by the surgery team. So now the picture at that, the labs at that time, almost normalizing hemoglobin, ESR 23, ANCA reduced to 19, CRB was almost normal, ferritin is also improving. So this is most likely or possibly drug-induced. They label it as a drug-induced colitis that responded well to the current therapy. So again, and MMF colitis with the presence of eosinophils infiltrates with the cryptitis and some ulcerations. But the patient was also he's having another manifestation of another disease, like de novo ulcerative colitis with the bloody diarrhea and band colitis presence with severe cryptitis in the colon. Are we having both together or only MMF colitis? And that is resolving. So the GI team was happy, we were happy, patient was fine, and exactly a year later, patient again, he's now 51 years old, not another 50 years. So at that time, this patient, he presented to the ER of Tawam Hospital with 4 weeks history of bloody diarrhea, up to 10 times with the blood clots. This time he has fever and he has severe abdominal pain. He was compliant to his medication. He was on tacrolimus 3.5 milligram twice daily. He was on azathioprine. He was not on any steroid. Tacrolimus trough level was seen, it was in the higher side, between 9 to 11 for the last 8 months. So what do you think is going on with this patient at this stage?
Tacrolimus level?
Tacrolimus level on admission was around 9. High, in the higher side. He is now almost, he was transplanted in 2012, so his target between 5 to 7.
CMV colitis.
Now you think it's CMV colitis, Dr. Muhammad, and okay, nice. CMV colitis. So blood clots and CMV colitis is unusual, but we will see what's going on. This patient.
Do exercise for again.
Okay, this patient now, they had done for him a CT scan. CT scan, you can see there's this is a transplanted kidney, and he is having left-sided colitis with proctitis picture and with reactive lymphadenopathy. And we arranged this time, we consulted the GI team. We sent again all the band cultures, the stool culture of a parasite. We are actively worried about what's going on with this patient. He has also leukocytosis of 14,000 with left shift, a high CRP, high ferritin level. And at this time, we arranged for urgent colonoscopy. And colonoscopy showed the following: severe colitis. This time, this colitis is mainly involving the left side of the colon. Transverse and the right side was almost normal, and the ileum was also normal. And the biopsy was taken, which shows cryptitis abscesses, crypt abscesses with severe colitis picture, and something else also there. So this patient, our differential diagnosis at this stage. Could it be a de novo post-transplant inflammatory bowel disease, like ulcerative colitis? Are we dealing with infectious colitis, or this is another drug-induced colitis? So what do you think at this stage?
De novo IBD.
De novo IBD. Anyone suggesting infectious colitis?
Possible.
Possible. Thank you, Doctora. So, at this...
Clostridium difficile could be pseudomembranous colitis.
والله شكرا دكتور. Highly appreciated. C. diff is negative. Yeah, C. diff sent, it was negative. CMV. Now, CMV from the blood is negative. But when we did CMV PCR from the colon biopsy, it was detected. So it was tissue invasive CMV. Okay, CMV
yes,
serology.
And this is a reason I was going to ask about, which is that here in your in the slide before, or 2 slides back, you stated that his tacrolimus trough level was very high for more than 8 months, and this is a question mark.
Right.
Why is the patient who is from the renal point of view, his graft is stable with only 2 medications, no steroids. One of them is azathioprine, and he's doing good, and he is over-suppressed. So at this point, the patient was over-suppressed, probably without an indication, because I mean, this is not the appropriate trough level for a patient who has been transplanted for so many years.
Appreciate it, Doctor. And this was also our concern, because the patient, he was, despite the fact he was attending to the clinic, there was a language barrier. He's Bangladeshi. And every time we'll explain to him, we're going to reduce the tacrolimus level from 3.5 to 3 milligram, or even lower. Patient was not following the recommendation. He was taking the same dose, 3.5 milligram twice daily, despite the fact of the instruction to reduce it. So this was an issue. Later on, we'll figure out what's going on with this patient. Thank you, Doctor. Appreciate it.
One more question, please, as regard this point. His creatinine was stable all through this period, while his tacrolimus level was very high.
Creatinine baseline around 85 to 99. During this tacrolimus level with the higher range, it was impaired, reaching the maximum 140. Well, creatinine, not more than that. Okay, so at this stage, CMV PCR was only found in the colon biopsy. I mean, when the pathologist review, there was no inclusion bodies. But when they have done the CMV PCR on the tissue of the colon, they found the CMV positive. CMV from the blood was not detected. CMV serology, I know it's relative use at this stage is not really helpful, but IgM was positive at that stage. Fecal calprotectin was really high, more than 200. So what you will do with his immunosuppressive medication, he was started on methylprednisolone IV. ID team was consulted and he was started on IV ganciclovir to cover the CMV tissue invasive disease. Azathioprine was reduced at this stage to 75 milligram, and tacrolimus was also reduced to 3 milligram twice daily with a repeat trough liver. This patient, after 1 week of therapy, bloody diarrhea was not responding. Patient clinically was still symptomatic. At this stage, the GI team decided that they will start this patient on infliximab therapy, and they shifted him from IV methylprednisolone to oral prednisolone tapering dose. And the ID team decided that this patient, they will give him induction they changed from ganciclovir to oral ganciclovir twice daily for prolonged, for 3 to 6 weeks. And this is what happens to our patient later on. Alhamdulillah, he was clinically responding. The diarrhea was improving. Patient was maintained on infliximab therapy, and the diagnosis was most likely de novo post-transplant ulcerative colitis. Infection was at this time in this presentation he has 2 in 1. He has tissue invasive CMV colitis at the same time with severe flare up of his ulcerative de novo post transplant ulcerative colitis. So at 2 in 1, he was treated for CMV and he was treated for the ulcerative colitis, but with immune therapy this time. Biologics this time was infliximab. And if you go back to the GI guidelines, the American GI guidelines for treating of moderate to severe ulcerative colitis, they were this based on the colonoscopy finding, clinical figures of the patients. And they mentioned the first line therapy for a patient will be you can use either of infliximab, adalimumab, vedolizumab, or tofacitinib. So this one, either one available, which is strong recommendations, and then based on this, you can escalate the therapy or continue on maintenance therapy. Bear in mind, some patients might be developing some antibodies against infliximab, and they might be not responding later on. So vedolizumab might be a better option with the lesser side effect. So I looked back if there is de novo inflammatory bowel disease in kidney transplant patients. At the time we had our case, it's only was only 2 cases reported in literature, and the majority of the cases they did systematic review. Majority of cases were from post liver transplant, de novo inflammatory bowel disease, post liver transplant, around 33 cases reported, and they have responded very well to vedolizumab, and some cases were also treated with infliximab. This was the largest case series that I could find in literature for the de novo inflammatory bowel disease in kidney transplant patient. They are from the Japanese team. They have done a large retrospective study for 232 kidney transplant patients. They could only identify 6 patients with de novo post-transplant inflammatory bowel disease. Majority of them having ulcerative colitis. Only 1 patient had Crohn's disease. and they responded well to the infliximab therapy, and as changing them to azathioprine therapy. And they mentioned there was no graft failure and no other extra-intestinal complications noted in such patients. So again, our patient was one of the rare manifestations, and he is one of the earliest patients who was treated, significantly showing almost complete resolution of his initial presentation with using vedolizumab therapy, and maintaining that for 1 year, and then having against a repeated flare with CMV colitis as a trigger in the second attack. With that, this was my last slide, and thank you a lot for your kind attention and active participation. The floor is now open for discussion and moderated by Professor YOUSEF boobes. Shukran.
Thank you very much for this nice 2 cases and little bit complicated cases. So now we open for more question if there is any.
Yeah, actually, it's not a matter of question rather than a matter of remark. And actually, this case is very interesting. We have transplanted probably a year ago a patient with a similar scenario. Actually, he was a patient with a known ulcerative colitis. He was on biological therapy. He was not responding in the beginning to vedolizumab, and then they escalated it to infliximab. Theoretically speaking, we thought that the patient going for kidney transplantation and receiving immunosuppressive therapy is going to suppress the ulcerative colitis activity. But when we looked a little bit deeper, and to me this was a little bit surprising, so we told him about the 2 points. The first point is that he was lucky enough that he was fully matched with his donor. There was a case of zero mismatch. Eventually, we told him that there is a possibility that after some time we might shift you from Silcept to azathioprine, okay, because of the negative side effects Silcept can cause to your GIT condition. The other thing that was surprising to me, I didn't know it before, something that they name a tacrolimus paradox. That there is some relationship between tacrolimus and its effect on lymphocytes. And I think probably it was for the CD8 cells, as I remember, that can cause in a way or another ulcerative colitis flare. One more thing that I would like to add, that Silcept-induced colitis has nothing to do with the tempo. I mean, it has nothing to do with the time the patient was transplanted. So if you think that your patient was transplanted like 10 years ago and he is on Silcept, he's doing good, so it's unlikely that Silcept could be the causative agent that caused this colitis. No, this is not right. Yes, it can cause, even though if the patient course was going very smooth, still Silcept can cause colitis. And one more thing for this patient, which is a good news for his insurance company, is that of course they will pay much less for his immune suppressive therapy when he was shifted from the Silcept to azathioprine. Thank you.
Thank you very much for this very good remark. Any other comment or question?
Yes, Professor Gobis, this is Dr. Seja again.
Yes,
Thank you, Dr. Fatima. Excellent presentation. Very interesting and challenging cases. My question is directed to you, Prof. YOUSEF. Any possibility that this patient have, in addition to the de novo colitis, IgG4, chronic inflammatory like inflammation that also can overlap his presentation? What is the IgG4 of this patient?
Yeah. Good point about IgG4. As you know, IgG4 is like systemic disease, which affect lymph nodes. It could be mimic Sjogren disease. And now, based on the biopsy, usually IgG4 in biopsy, when you take it, it's mainly plasma cell infiltration labeled with IgG4 also. So I don't think this biopsy of colon was typical for or suggestive of IgG4. Although I don't think they stained it for IgG4. But we have a few cases of IgG4 with renal involvement. It's respond dramatically to steroids. And in rare cases, when it is resistant or relapsing, then we can use anti-CD20 medication. Yesterday, I have one of these cases who relapsed after 1 year. He received the first dose of rituximab just yesterday. So good thought, Dr. Saja, but in this case, it is not suggestive of IgG4.
And what is the long-term immunosuppression for this patient planned? Yani, what is the target like tacrolimus for him? What is the any suggestion for like removing tacrolimus to everolimus and any other alternative immunosuppression?
I agree that his tacrolimus level should be at a low range around 5. With azathioprine, modest dose 75 milligram. Now, the replacing it by everolimus, I don't have enough data to show that this is beneficial for this patient. But it is one of the possibility if there is some resistance to treatment. This case, when it's relapsed, we have additional element, which is CMV infection on top of the ulcerative colitis. But for sure, MMF in this case should not be attempted at all, because it will not make things good for the colon. Now, I will personally, unless I have clear evidence that everolimus or sirolimus has a better outcome, I will try to keep him on tacrolimus at the low therapeutic range. And there is no evidence-based data to support my opinion or other opinion in this regard.
Thank you.
Welcome.
Can I put one question?
Sorry?
Can I put one question? Miroslav is here. So maybe it's not so much relevant, but it's, for me at least, was very interesting. In the beginning of the story of the second case, while the patient had a very broad spectrum workup, basically it was mentioned, if I'm not wrong, that C4 level was very low. So how can you interpret this finding for him? Just like an incidence, or it had some pathophysiological contribution?
Dr. Fatima, you have the number? C4?
C3 was normal, Professor Youssef. C4 was in the borderline low.
Yes.
But when we repeated, it was normal. It was found at the same time when we had the C-ANCA in the higher side. We are not really sure if there is any link, but when we read about the severe ulcerative colitis, there was some few studies that if the patient have ANCA positivity, especially C-ANCA, And then with high ESR, this patient it's indicative of severe mucosal injury. It's grade 3 to 4 Mayo classification. And they found such patients would be at higher respond to biological therapy rather than oral, because if you remember the stepwise therapy, he was given steroid, he was shifted to azathioprine, but he was not really responding, and then we have to go to biological therapy to where the patient responded. But why C4 was really low, and it was only borderline low, and when we repeated it was normal. I'm not really sure if there is any link between it and ulcerative colitis. Thank you for your question.
Yeah, if there is a activation of classic pathway, usually you will see also consumption of C3 if it is significant. So this is a marginal drop, and whether it's significant changes or not, I'm not sure. Thank you. Any other question?
Actually, for the point of the C4, as you, Prof, stated, that it is supposed to be normal or even elevated, because at the end it is an acute phase reactant. So for me, for this lab marker that was not coping with the whole clinical context, I would do things. I would ignore and I would repeat. But as long as the patient responded to the suggested plan, he responded dramatically. So probably if we repeated the C4, it would come even normal or probably elevated, coping with higher disease activity, because at the end, it's an acute phase reactant.
Yeah. Thank you. Any other comment or question, please?
If I can ask my last question regarding the patient that responded very well on the vedolizumab as a first-line biologic treatment, why he was started on another line instead of maybe to repeat vedolizumab if vedolizumab was working very well in the first instance. Thank you.
Yeah. Doctora.
Okay, thank you, Doctor, for this again. Excellent question. As I show you in the guidelines, is first line you can use either because our patient is biological naive. So on this patient, we have the two options, infliximab versus vedolizumab. Vedolizumab, because of his insurance was not covering that, infliximab was covered. That's why we used infliximab in this patient. And the patient, alhamdulillah, he's maintaining now for 2 years on this therapy without any admission or a flare-up. He's doing well in terms of the GI, with the last colonoscopy showing normal mucosa, and he was still maintained on azathioprine and tacrolimus with a lower trough level. Thank you.
Congrats for this case.
Yeah, just small comment on that. This patient, what complicated his story, two things, in fact. One is the issue of coverage, and I really thanked Dr. Fatima. She took the initiative to call the patient, try to push him to come to receive his medication through emergency room and so on. But it was not easy. The other thing, the patient was not so keen for serious follow-up, and although there is, she mentioned we have some communication issue, but also it's like ignorance and not taking things seriously until he has significant problem. So his follow-up as outpatient was not so smooth in many aspects.
Okay, Dr. YOUSEF, also I think that the gastroenterologist has a big role in these issues. Well, pathology is very confirmative and diagnostic in this case. Then it is isolated GI table possibility. You got my ideas? فالinput of the gastroenterologist, especially if he's reliable, dependent, it will be guided the management of this case.
Yeah, I totally agree with you, and this is what we did. As nephrologists, we have limited experience with such severe cases of colitis and other. So we worked closely as a team with our great consultant in GI, and in fact, we have one of the best GI consultant in UAE, and his input was helped us a lot to save the life of this patient. In fact, the thing that we need to learn from such cases, that we have to take all symptoms seriously, especially if the patient has severe symptoms, and take action very rapidly, and try, because it might end by a patient losing his life. And they were very cooperative, and we really had great input from their part. Sorry. Thank you.
Okay, the same for MDT approach is very essential in management such a clinical pathway. Very essential. A nephrologist by himself, he cannot put too much, especially for this complicated cases. Yes.
Definitively, especially when you are in a tertiary hospital with such rare cases, rare disease, and as the first case Dr. mentioned, maybe there are 4 cases reported in such a condition. But this case, it's more serious for the complication and life of patient. We need MDT approach, and the concerned subspecialty should work close to each other. I think if there is no more question, we can close, or any more. I can't see the hands, if there is any hand up.
Just I want to add to Fatima that I'm very pleased to be attending this meeting. Fatima was our best fellow in the renal replacement therapy and blood purification program. Fellowship just ended with an excellent degree. So I focus today to attend her quizzes with Professor YOUSEF. We met before. So thank you very much. I really enjoyed that.
Thank you a lot, Professor Hisham, to take from your busy time and to be with us and sharing your expertise in this case.
It was
Thank
really
you.
pleasure. Yes, was really pleasure. Yes.
We are really honored, Professor Hisham and Professor YOUSEF, for your great contribution to the cases discussed today. And our aim is to share knowledge. And with time, if there is a challenging case, this is what I learned. If there is any challenging case, go back, read, update yourself, discuss with your seniors, and come up with a plan, and hopefully good outcomes for your patients and the community you are dealing with. Appreciated all the discussion today. And again, thank you, Oman Society of Nephrology and Transplantation. Thank you, our dear Professor YOUSEF Boobes, for great moderation, and Professor Hisham Said for your great input, and all my colleagues who attended this meeting today. السلام عليكم.
كل سنة وانتم طيبين. اشوفكم على خير ان شاء الله.
شكرا جزيلا. Thank you.